So now we're going to move on to chapter 6, and this is about the hospital industry. So in the 19th century, hospitals could be fatal places to go for medical care. This was, you'll remember from chapter 5, when physicians were also not very heavily regulated, but just going to the hospital could actually have a higher mortality rate than staying at home at that time. So in the late 1800s, there was a lot of innovation that helped lift the reputation of hospitals. The idea that germs cause diseases, so they started having antiseptic techniques. Things like anesthesia would make it a lot more pleasant to undergo something like surgery, and also x-ray technology could really help diagnose a patient more than what they can do at home. So it increased the demand for hospital services and surgeries and led to an increased need for hospital resources. In 1946, the Burton Act increased the number of hospitals in the United States. So Congress gave money to build hospitals, and any hospital that was receiving this money was also required to provide free or low-cost care to people who couldn't afford to pay. And so the result of that act is that we have more hospitals and more hospital beds, as we see today around the country. Over time, more recently, technological advances have reduced recovery times, and that combined with the way that insurers are paying hospitals has led to more and more outpatient care and shorter and shorter length of stays in a hospital. So you can see the graph on my left. I see it increases the number of outpatient visits in millions, and that's just steadily increasing from 1967 to about 2009. And then on the flip side, the length of stay in a hospital is steadily decreasing over approximately a similar time period, the mid to late 20th century. So that's what we see. We see a trend towards an increase in outpatient visits and decreasing length of stay. So hospitals are the place where these things happen, and they have to have a relationship with the physicians who are doing the diagnosing and treatment. Some of them, mostly in the U.S., where physicians are not directly employed by the hospital, they work for a few hours or kind of have like a contracting relationship. In other places, like the National Health Service of the United Kingdom, and also some in the U.S. as well, they are direct employees. This is called being a hospitalist. And it's just when the employee is the one who's, sets your hours and is like officially your employer. In Japan, actually, and sometimes in the U.S. as well, we have physician-owned hospitals and physician-owned clinics as well. So these are the different modes of the relationship between hospitals and physicians. And there are trade-offs between these different modes. So is the physician loyal to the hospital or to the patient if the hospital is their direct employer, for example? But then if the doctor has no connection to the hospital, they might be more likely to overutilize the hospital resources. Whereas if they own the hospital, they might be more frugal or prudent with those resources. We do see that there is a positive correlation between volume and outcome. So the more frequently a particular hospital or clinic team does a surgery, the better it is at doing that thing. So we see that surgical mortality rates decline with increased hospital volume. So what this graph shows you is these columns are stratified by hospital volume, and they're the different procedures and their mortality rates. So for coronary artery bypass grafting or CABG, for the lowest 20% in terms of hospital volume, we have the highest mortality rate. And you can see a statistically significant difference between the middle and highest 20% groups by hospital volume. I guess pancreatic resection looks like it has the biggest difference by hospital volume. And the same thing is true for colorectal cancer resection surgery rates. I worked on a paper once with my advisor when I was a graduate student. Her name was Pamela Farley Short, and it was about Appalachia, colorectal cancer resection rates in Appalachia, where transportation and distance is a big factor. But they had been investing in these big regional cancer treatment facilities. But a lot of people, it's really hard to get to that big regional center, and they end up having to go to the one that's closest to them. And they found that The people who bypass the one that's closest and keep going to the next one, they end up having lower mortality rates. So it's not just about the fact that they happen to live in a city, it has something to do with the actual center. And so why do we see the relationship like that between volume of the hospital and the outcome of the patient? There are two hypotheses. One is learning by doing. Perhaps you've done it so many times and you are able to do a good job through that process. Another is that it's maybe a selective referral. They do well, so people refer more patients to those hospitals, and that leads to the correlation with high volume. But actually, evidence suggests that it's the hospital volume that it's actually the hospital's experience that drives the outcomes. But so, which one would you prefer? Would you rather have your surgery with an experienced physician or in an experienced hospital? Which one is more important? Is it the hospital's experience or the physician's experience? You can pause and think about that for a second. So there is empirical evidence to suggest that those hospitals with more surgical experience, similar to this paper that I wrote with my graduate advisor, but in general, hospitals with more surgical experience have fewer complications than when it's just the physician that has the high experience level. And so that finding makes sense if you think about the way that medical workers collaborate on in a team-based way on the surgery. So each individual physician's experience is actually less impactful than the group's joint experience.